because without you guys looking and holding the fort, the rest of the healthcare system will not be able to do what they are supposed to do. And my kudos to you guys. And I think there are a lot more people out there who are actually looking forward to thank the healthcare workers out there like you guys, 20% free meals and what have you. Okay, with that, I thank you for your attention this afternoon. And we are open for a discussion in terms of a Q&A. We're going to try to see whether we can have that. All right, so I have this question on what's the ENT approach to patient with a persistent cough. So I presume when we say persistent cough, we're going to divide them into acute and chronic, yeah? Anything more than 3 months or 12 weeks is chronic cough. Let's go to the persistent chronic cough. So chronic coughs, we do have to look at a few big causes: upper respiratory tract, lower respiratory tract. If not, it's the gastrointestinal tract, all right? So when it comes to, we look for history, we look for signs and symptoms. History, I'm always look for any signs of any purulent discharge, whether any coughing out of green, yellow stuff. Where the symptom is it mainly nasal symptoms, any nasal symptoms, throat symptoms, any associated throat symptoms, any headaches, any blocked ears, any affected areas around the region. The moment you have green, yellow mucus, you're thinking about highly to be more infective rather than inflammatory. So you want to look at sinus infection, nasal infections, adenoid infections, tonsil infections, and of course you can have pneumonia and stuff. And then the non-purulent, non-discolored drainage, phlegm, throat discomfort, you need to think about gastroesophageal reflux. Now the only difference is I can do a scope on patients and verify whether there are pus that's sitting inside the sinuses, just like the 10-year-old boy that presented to me. Actually, he had very minimal nasal symptoms, but you look at, in the end, what our diagnosis was: severe acute sinusitis with orbital complications. So a lot of times, you may need to re-look at your diagnosis or rethink about diagnosis when the usual medicine is not working, or the presentation is a little bit different, out of the ordinary. And this is where our index of suspicion as physicians, as doctors, need to come in. If X-ray shows sinusitis, how long duration should we prescribe antibiotics? Is CT scan mandatory? I think a lot of times sinusitis can be diagnosed based on history and examinations. X-ray sinuses has been known to be not very accurate. Okay, not very accurate. Because if based on clinical acumen already, you can diagnose basically treatment, you carry on with antibiotics and whatever adjuvant you want to give to the patient, plus minus steroids and stuff, nasal washes, and start the treatment, all right? Because the patient response will tell you. Now, the X-ray, sometimes a negative X-ray still can be positive for sinusitis. That's what I'm going to tell you, okay? So it's not that reliable. CT scan, to me, if I have a patient cough for 3 months, this and that, done everything out there, just like the 56-year-old lady I had, if the last ENT doctor had bothered to do a CT scan, he would have gotten the diagnosis straight away. All right, to me, the CT scan is very important to exclude the sinusitis diagnosis. All right, and I emphasize on the word exclude, not to confirm, but to exclude. Because if you want to see negative, you need to be 100% sure it's negative. Is Vilastin safe in peri-pregnancy and breastfeeding? Good question. We have heard that question asked before in many forums. At this point of time, there's not enough data out there to show its safety and efficacy for this particular population of patients. Yeah, so just not enough data because there's not long enough time and to do it, and then there are other alternatives out there. Another question from Daniel is, we are now being told that anti-inflammatories such as steroids and ibuprofen affect the cause of COVID-19. Yes, you're right. I got that on my chat group as well. Should we all stop using nasal steroid sprays and inhale steroids like Symbicort for those with chronic allergic rhinitis and bronchitis? It's a good question, but I would like to emphasize we are here not to only treat COVID-19. We are treating other illnesses as well. You need to do, as far as evidence-based is concerned, you need to give the patient appropriate efficacious treatment. You cannot give our patient half-baked treatment and yet at the same time trying to so-called make the COVID-19 less likely, I think. I don't think there's any fast and hard rule, but pretty much to give up whatever you've been doing for the patients just at this time may be a bit too much to ask, especially for patients who needed those medications to keep themselves well. I think the jury is still out at this point of time. I don't think we are seeing that kind. I don't think locally the doctors have noticed that in our local population compared to the Italian cohort, which is what I understand from. Is there any difference in efficacy between antihistamine with decongestant or just plain antihistamines for treating rhinitis, infective or allergy related? Now, decongestants is very good to relieve nasal congestion. If your patient has a lot of swelling and stuff and requires decongestant, then you add in a decongestant. Antihistamine works very well for sneezing, itching, and runny nose. May not be so good with the decongestant part. It can work a little bit, but it depends on your patient's symptomatology. If very bad nasal blockage, you need a decongestant on top. If not, usually the sneezing, itchy, runny nose, antihistamine will suffice. How long can patients use intranasal steroid for allergic rhinitis? At this point of time, if it's as young as 2 years old, can use. I think the length of time, I don't think there's a limit to how much, because remember, this is a topical drug. This is not ingested into your body. And so far, the bioavailability inside your bloodstream is extremely low. So it's extremely safe, right? It doesn't even affect the child's growth and development. So I think rest be assured, it can be used for a long time. MRI better than CT in sinusitis? I would say CT scan because it does very well for bones. The bone window for CT sinus is the best to evaluate any CT sinuses, inflammatory problem. Gives a good roadmap as well. MRI we do to assess soft tissue, so very good for tumor cases. All right, if we expect the tumor to be invading into the soft tissue and stuff, I would do an MRI. But run-of-the-mill sinusitis, CT is the gold standard. What antibiotics for an infective sinusitis? Augmentin or Clasid or quinolones? Sinusitis, so we divide into acute sinusitis as well as chronic sinusitis. Now, most of the acute sinusitis out there, we have guidelines. We have guidelines to talk about which are the first line, second line antibiotics. Again, that's one thing that you can follow, and a lot of people do follow. But the other thing is patient profile. Like I think today the discussion from that little survey also show you that the patient profile is also very important. A lot of us do have long-term patients coming back for their recurrent acute infections. Some of them may experience that, super bad side effects, diarrhea from certain group of medication, get very bad heartburn, people start getting rashes. So depending on that, it can range from Augmentin to Levaquins. You have allergic to penicillin, then we are left with the quinolones. Really for acute sinusitis, anything out there. Now for the chronic sinusitis, I tend to like to do I did like to take some samples, culture, what I call culture-directed antibiotics. So a lot of times I give them adjuvant therapy, wait for the culture. I actually suck out the pus, send it for culture. And from there, we then find out what bacteria is grown, what is sensitive to, and then we start on the antibiotics, especially for chronic sinusitis, because I just don't want it to complicate matters where we start something and then it contributes to the long-term resistant problem. Okay, and with that, I thank you very much for spending your lunchtime with us, and look forward to seeing you again in the next webinar that we'll be having in the next couple of weeks to a month. All right. Thank you very much. Have a good afternoon. Bye.